On to the next segment with Dr. Ahmed Al-Basiri on documentation as a junior. Dr. Ahmed, the mic is yours.
يعطيك العافية Dr. Ali, and thank you for the invite. First of all, my name is Ahmed Al-Basiri. I am currently in the Kuwait residence in the Kuwaiti Board of Family Medicine. And I spent actually 2 years in Mustashfa Mubarak as an assistant. So I think I met some of you guys. I think I recognize some of the names there in the question section. So first of all, a massive congratulations to all of you. This is a wonderful achievement, and I hope you got to celebrate it with your friends and family. So for today's talk, I'm going to talk about the documentation process as a junior. So we have 4 types of documentation. The first one is the admission note. So the admission note, this is the note that you are required to do when the patient is first admitted to the hospital. Now, the patient will have already been seen by your registrars or your assistant. So you will have an idea of what the case is. So you will meet that patient when they are shifted to the ward. What is required of you in the admission notes is you want to retake the history again. You want to do the physical examination again. You want to check their vitals, and then to follow through with the plan. So this is what I'm going to talk about in the next few slides. So if I can skip to the next slide, Ali. So as I said just now, so when the patient first comes to you, the first thing that you want to do, or the first thing that you want to write in the paper, is the patient name, their age and gender, the relevant medical history, and the surgical history, if it's applicable. And you want to also add out if there is, or you also want to add in if there is any recent hospital admissions or the ER visits as well. This will paint a picture of if there is something going on with the patient before they came in. And then after that, you go in with your detailed history. So I think most of you know, like by now, how to take a proper history. So that includes the functional history of the patient. So how was the patient at home before they came here? And again, that just paints a picture of how the patient was doing before. And then you can compare between how is the patient at home and then how is the patient now. So that's the functional history. Then you want to go into detail here with the list of their home medications. You want to know exactly what they're taking because it's very, very important for your team to know, so that they can include these medications in the plan. After that, you want to do the vitals again. So the vitals would have been done already in the ER, but now you want to take the vitals again and record them because you want to compare of how is the patient is doing before and after they came to the ward. So, and what I mean by the vitals, I mean blood pressure, the oxygen saturation, the temperature. This is all very important. The next one is the physical examination. So you want to do the general inspection of the patient, if they are conscious, alert, and oriented, how they're looking, if they're looking well, if they look anemic, if they're having difficulty breathing. It's all very important to note and to document as well. And then you want to do the cardiovascular exam, the chest exam, abdominal, and if relevant, you can add other kind of examinations like the neurological examination. The investigations again would have already been done already, so there's no need to request a new one. But the next one is very important. You have to document in the file when you receive the patient. How was this patient managed in in the ER. That's very important. And even if you will be presenting the case to your consultant, because your consultant, for example, was not present, they will be asking you this question: what was done for this patient in the casualty? So you really need to focus on that part here. So again, you have to re-examine patient, get these new set of vitals, and to compare them with what they came up with first. The next slide, Ali. All right, so this is just an example. It's a bit of an exaggerated example, really. So I'm sure most of you are familiar with Steve Rogers. So Mr. Steve Rogers is a 106-year-old gentleman with a known history of asthma, atrial fibrillation, and hypertension. He is walking independently with occasional use of walking aid over long distance. So this is just, it paints a picture of who this patient is. He has a significant family history of cardiovascular accident and acute coronary syndrome. His last visit to the ER was 3 weeks ago with hypertensive urgency. So this is kind of like a red flag to you that this patient maybe is not compliant to his to his treatment. And then the patient is a non-smoker and claims he had never used any recreational drugs. Okay, then we can go to the next one. So this just like paints a picture to you of who this patient is. So then we go into the typical history that you are that you do like most of the time, which is the presenting complaint history. So Mr. Rogers was brought in by the ambulance with a sudden onset of left-sided weakness. So there you go. That's the presenting complaint. He was sitting at home and he experienced that weakness. The emergency medical services were contacted and they brought him to the ER approximately 30 minutes later. He had no previous history of these symptoms and no history of loss of consciousness or trauma, and he denies any of the following symptoms. So this is just briefly what you would typically write as the history of presenting complaint. Of course, you can go into more details, but this is just to give you an example of like how it looks like. The next slide. All right, so, and then we can go into the medical history, if you didn't mention it before, the surgical history, but we've already mentioned it now. And then the medications. So Mr. Rogers, he's currently on Norvasc 10 milligram, Concor 5 milligram, and Xarelto 20 milligram. He has no known drug allergy. He's an ex-soldier who lives at home after his late wife's passing, and he is a non-smoker but a social drinker. Next after that, so if you're the one doing the vitals, or if you receive this patient afterwards, you want to do the vitals. So these are the vitals. You want your ECG findings. You want your examination. So you do the examination. He was conscious, alert, and oriented. And I only mentioned here the neurological examination just for the sake of time. So the neurological examination showed normal tone, reflexes, and coordination. There was a flaccid weakness of the left upper and lower limbs. And then, if you want, you can also include the relevant scores. So in this case, it's the NIHSS, which was 9. So after you wrote all of that, you want to go into the labs and investigation. So this is your typical picture of the initial labs and investigations. Of course, you'll go into more details like further on. And then the CT was done here as well, and the CT did not show any acute intracranial abnormalities. So that's your labs and the neurological investigations. And then finally, like as I said, you want to document how this patient was managed in the ER. Has this patient actually been seen by other subspecialties and or the ICU? It's very good practice to include a differential diagnosis. When this patient, like if they arrive to your ward, you will already know what the case is. So it's good practice to formulate a differential diagnosis. And then also for the plan, it would have already been set by your seniors. So it's also good practice to come up with yours and just compare with the original plan. So that's really it for the admission note. This is probably the longest one, and we're going to move next to the progress notes. And Dr. Faye, she actually explained that very well. So we're going to go with the SOAP formula. Of course, like before you do that, you want to document the patient name, age, and gender, the past medical history, and the working diagnosis. So the working diagnosis is the first impression of the team for this patient. After that, you go into the SOAP. So first is the subjective. So how is the patient doing today? Since you last saw them, is there like any new symptoms that they have been experiencing, and are they responding to the treatments well? So that's the subjective part, and then the objectives. You will do your vitals and examination every day for every patient. This is very important because you want to compare to the day before. It gives you a picture of an improvement, or, for example, unfortunately, if the patient is worsening. The A, so this is the assessment or the active issues. So it's basically why is this patient still in hospital? It gives me a picture of what is delaying the discharge of this patient, and I'll go into an example, I think, after this slide. And for the P, which is the plan, it's basically the plan that is set by your seniors. Again, it's very good practice to formulate your own before your seniors tells you what to do. So I'm going to give you an example, I think, for the next slide. Just to clarify, this is not the handwriting of a 5-year-old. This is actually my handwriting. So I hope you can read that. So as you can see, I went into the patient identifiers. I explained what is the working diagnosis. Then I went into my SOAP. So the subjective, objective, the active issues down there. So for each active issue, you want to write down what is the current management that the patient is getting for that specific issue. So for example, if the patient was admitted for an ischemic stroke, so for example, this patient is currently on aspirin, and then after 2 weeks, we will start him on anticoagulation. If the patient is in AKI, the patient was seen by nephro, and they wanted to do this and this and that. So that's what you do. You'll be writing the active issues and what has been done for each active issue. And then at the end is the plan. So like you would write, the patient was seen with Dr. like Ahmed or something, and then you would go 1, 2, 3. And then at the side there, it's like, this is just what I do. I just include also the IV fluid if the patient is on any, what kind of diet they're on, and so on. So that's like how to do the progress notes. Okay. Next one is probably sometimes people can find it a bit challenging, which is the consultations. There are 2 types, the written and verbal. The challenging one is the verbal because it requires a decent set of skills, of communication skills. So the goal of the consultations here is you want to summarize the patient's hospital course for the subspecialty that you are trying to reach. The second goal is you want to provide them with the relevant information that they care about. So if I'm contacting the nephro, I don't want to talk to them about how has the patient been doing with regards to with his or her ischemic stroke. So that's in terms of the relevant information. Then at the end, you want to state clearly what is the main reason for the consultation, and what do you expect of them for this patient. In addition to this, so I just want to like mention before I go into the example of the written consultation. With the verbal consultation, you want to first introduce yourself very clearly, and on behalf of which unit you are like contacting them, and then you have to really know your patient inside out. If you don't, and sometimes you have a lot of patients, just make sure that the file is directly in front of you. That will help you massively. So I'll just give you an example here of a written consultation. So first you would say, dear colleague, this is just like very polite. May I refer to you, Mr. Rogers? And then you give them the past medical history. He presented with working diagnosis of right-sided ischemic stroke. Then you will tell them what happened very briefly. And then you give them the important details. So his RFTs were normal on admission, but the creatinine has recently become 120. It was 90 before. The potassium now is 5.7. So that's another like reason for them to come. And the urine output is 300. So I gave them all the relevant information that will let them know that this patient needs to be assessed by us. Then there at the end, you'd say reason for consultation. We would like a nephrology opinion with regards to his AKI management. Thank you. And then that's it. That is the consultation. If you guys have like any questions about that, I'll be very happy to answer it later on. But I think we're going to move on to the next documentation, which is the discharge summaries. Now, this is the easiest out of all of them, but it's the most time consuming. With the discharge summaries, the goal of it is you want to talk to the next healthcare professional. So you can use as much medical jargon as you want, because this discharge summary is meant for a healthcare professional. So when you start writing your discharge summary, you want to mention the date of admission, the date of the discharge, what is the final diagnosis, and then you mention the patient name, age, and gender, the full list of past medical history and surgical history. That's very important to include. Then you want to briefly summarize the admission notes for that patient. So what they came up with, what was the initial labs and investigation, and what was the initial management. Then next, you're going to talk about the hospital course. So this is just a summary of the active issues. Like my way of doing the hospital course is I go by active issues. So I would say the first active issue was ischemic stroke. We did this and this investigation, and it showed this and this and that. And then we treated this patient with this medication, and then later on we changed it, for example. Then next would be, let's say, an AKI. So the patient first was doing well, the creatinine was 90, then it was 120. We called nephro, and they advised to start IV fluid and like to hold some of the medication that might have caused his AKI, and so on. So that's 1, 2, 3. After you finish your active issues and all the sub details there, then comes the discharge plan. The discharge plan is your consultant's or the team's plan for this patient. So it basically includes the medication that this patient will be on after the patient goes home, what kind of labs and investigation, whether it's like blood investigations or the radiological investigations that you require them to do afterwards. If this patient requires a follow-up afterwards with the medical team or the surgical team, or the neuro team, or sorry, the nephro team in this case. So you just mentioned that you would like that to be done. And then if needed, if there's like any referrals for this patient. So if this patient came with an ischemic stroke and he's having left-sided weakness, you want, for example, to refer this patient to the PMR, which is physical and rehabilitation medicine, or something like that. So that will be the whole of the discharge summary. I'll be sending you guys the full like details about the discharge summaries in a separate presentation. So the guys over at KRC will be helping you with that. And that's it for like the talk that I have this afternoon. I hope it wasn't very long, but if you have any questions for me, I'll be very happy to answer them later on.
Thank you, Dr. Ahmed, for that talk about the notes, and you went into details. Well, I'll be happy to send those documents to all of those attending. So I hope you've enjoyed that segment. Thank you, Dr. Ahmed.